Hey guys, this is Brian Atkins, filming a online lecture for the neurology review for the clinical performance exam. I hope you guys don't mind the online format, and judging by the attendance of class when I went to the lecture series today, I don't think you do mind it. I feel like this was a good lecture to have available in asynchronous fashion because it does not fit into the basic lecture series and is not testable for the written exam. This lecture is solely for review for neurological illnesses you may be rusty on since your neuro block was last year. To give you some history, we covered more neurology last year in the ICM course. However, most of that information was asked to be moved to the neuro block, which makes perfect sense. However, going into the clinical performance examination, I did not want you guys to be out of practice on these illnesses. The good news is since this is not on the written examination, I would hope that you'll watch this lecture, kick back, and take it in for what it's worth to you as a future clinician and how it can help you in performing on the clinical performance exam as well as differentiating these patients in your future practice. I do not want this to be a point of stress and have people printing off the PowerPoints and memorizing each slide by slide. Now, there is plenty of important information in this lecture, but the most important points that aren't so obvious will hopefully be on the study guide that I'll prepare and send out to you guys for the clinical performance exam. Now, as you guys may or may not be aware, there are a list of about 40 pathologies, which could be a major presentation for a standardized patient on the clinical performance examination. Those are the ones you're responsible for knowing well and in detail and being able to pick out based upon the patient's history and physical exam whether they have that illness. There are 10 of those that are neurologic, and those are the 10 that we're going to cover today. This is not intended to be a global review of neurology. This is not intended to replace anything you covered last year. This is merely a supplement. Now, if you're looking at things that are most important to take away from this lecture, it's background information on these, which include history, physical exam findings, and what physical exams are most important for these illnesses. I'm going to put in statistics on these illnesses. I'm also going to put in information about how you would work them up, radiographic images, and treatment. Obviously, on the clinical performance examination, you will be walking into a standardized patient, inquiring their history, performing a physical examination, and then generating a differential diagnosis based upon their presentation. You'll choose your number one guess as to what the answer is, and then you'll generate two other alternative plausible hypotheses for correct answer, and then in a short few sentence essay question, answer why you felt it was number one and why you thought 2 and 3 would also be reasonable estimates. So if you look at it that way, you will not be tested on the treatment, you'll not be tested on the workup, sheerly on the history and physical examination. So we'll go ahead and get started after I get through 2 more disclaimers. Number one, I'm filming this in my basement in my man cave in the middle of the night on a Thursday night, and I'm using QuickTime to do a screen recording video. I hope it works out well. My iMac has a microphone on it, but I have a PlayStation 4 headset that looks like something Britney Spears would have worn, or Garth Brooks with a wraparound front microphone that I bought so that I could play PlayStation 4 against my 8-year-old nephew, if that tells you anything about the maturity of your instructor. So I'm hoping to use that, so we'll see how good quality the GameStop $25 wraparound headset is for the audio on this. The next disclaimer is that I'm the kind of person who usually likes to mix in a lot of personality in my lecture with a lot of funny and sarcastic and irreverent topics and photos. However, since it's an online lecture, and since I have a whole lot of stuff other going on with my newborn and a variety of other things, I did not have time to really prepare a good comedic portion of this lecture. I feel like the comedy is best served in the live setting, and since it's a online lecture. If it gets really dry, you can just hit pause and walk away. So my apologies for probably putting together the most boring and dry lecture of my academic career, but we'll go ahead and get started. So here are the neurologic pathologies you may encounter on the clinical performance exam. Subarachnoid hemorrhage. We also mentioned parenchymal brain, intraparenchymal brain hemorrhage, but I think subarachnoid will be the major form of head bleed, so to speak, that you should be familiar, and I focus mostly on that. Ischemic stroke, transient ischemic attack, or mini stroke, migraine, tension headaches, temporal arteritis, acute meningitis, seizure, syncope, cluster headache, and brain tumor. Like I said earlier, this is not for testing. This is a lecture for background of clinically pertinent information to assist you and provide a refresher for the neurologic pathologies that you may encounter on the clinical performance exam. It was not feasible for us to drop all the neurologic cases that we've created for the examination because they're some of our best cases. Over the course of this year, not only in your regular sessions, but in your ER sessions, I hope you've been seeing neurologic patients, including patients with strokes and headaches, which I think are probably the most common ones, occasionally syncopes that you would be seeing on your preceptor rotations. And so I didn't feel like that it would be wise to leave those portions out of your clinical performance examination. They're very important going forward. So I'd rather spend a few hours creating a lecture and a refresher than I would to take away those things off of the clinical performance exam. Just pay attention and consider the important points. Again, like I said earlier, this is not intended to be a complete review. This is just for 10 illnesses that happen to be covered on the clinical performance exam. Ischemic stroke, also known as cerebrovascular accident. To be really put it simple, for a stroke, it's loss of blood circulation to part of the brain, which causes that part of the brain to infarct and die. And you get neurologic symptoms and deficits that occur based upon what part of the brain died. I don't think anybody ever explained it to me quite that simply when I was in school, but if you think about it that way, it's not that hard. It can be caused by thrombotic or embolic occlusion, so that basically means either the pipes are clogged or something broke loose and went downstream and clogged an otherwise patent piece of plumbing that was leading to the brain. There are both ischemic and hemorrhagic strokes. For purpose of clinical performance exam and this lecture, we'll focus on the ischemic strokes. Probably more than 9, up to about 9 out of 10 strokes are ischemic and not hemorrhagic. We'll talk a little bit more about hemorrhagic just for your own information, but for the purpose of clinical performance examination and this, we'll focus on ischemic. There are 3 types. You see large and small vessel and cardioembolic. One of the most important things to pick up here is the small vessel strokes. Sometimes it can even go silent and you don't notice them due to microvascular disease. The large artery strokes are the common presentations that we'll cover later on, such as the middle cerebral artery, where an obstruction from arteriosclerosis or a plaque rupture will fill up and occlude and lead to ischemia and infarction. Very important below there, cardioembolic. That's about 20% of your strokes. And the most common cause of cardioembolic strokes is atrial fibrillation. I think you guys are probably familiar with that from your cardio block and also the ICM lectures. But basically, the heart beats ineffectively based upon the presence of the atrial fibrillation, which leads to intrachamber formation of clot and thrombus, which can be ejected as an emboli into the arterial circulation and occlude in the arterial circulation to the brain, creating the same effect of a stroke. The reason this is extremely important in learning about the clinical performance exam is that's why every patient who has a stroke or some alteration of level of consciousness, such as syncope or seizure, the differential diagnosis would include a cardiac cause. If you see someone who has what you think is a stroke, a mini stroke, or something that presents with an acute neurologic deficit, I think it's wise to think that you should perform a cardiovascular examination on that patient. Now, when you see a patient on the standardized if you see a standardized patient with what you believe is a stroke, you will be expected to perform the cardiovascular exam just like the neurologic exam. It'd be helpful in picking up, in the real world, it's helpful to pick up if someone has an irregular heartbeat, such as atrial fibrillation or murmur or some other focus of an embolic source. To give you background on that, my grandmother actually had, on Christmas Eve when I was a child, had a stroke. She did fine after that, but the cause was atrial fibrillation. And I remember that my grandmother had to be on Coumadin, which is a blood thinner that involves the vitamin, or warfarin, which involves the vitamin K pathway, for basically the rest of her life. And you'll commonly see patients who face both the difficulties of anticoagulation and difficult decisions whether to anticoagulate or not anticoagulate based upon their other risks. Now what I have here is a picture, basically a color-coded picture of where the different arterial circulations affect the brain. Obviously this isn't something you'd be on your clinical performance exam, but you can see here the red area is the middle cerebral artery distribution, and that would determine what neurologic deficit someone had based upon the area that is shaded out for the artery that they knock off. To your right, as you look at the screen, is a angiogram, which is basically a dye-based study to evaluate the arteries. It's not too uncommon now in a more aggressive stroke treatment world for patients here in the emergency department and upstairs to get CT angiograms to try to identify if there's a large vessel obstruction so that they can identify the next most appropriate therapy. Risk factors are the same risk factors that lead to any vascular disease. High blood pressure, diabetes, high cholesterol. Obviously, if you have carotid stenosis, which is a type of already existing vascular disease, then that can obstruct flow of circulation to your brain and create, and severe tenuous lesions can create strokes themselves. Cardiac disease in the absence of vascular disease, structural cardiac disease such as valvular disease, mitral stenosis, as well as rhythms like atrial fibrillation and the existence of heart failure can all contribute to an embolic source or cause of stroke. As you see there, structural abnormalities leading to right to left shunting like the patent foramen ovale or PFO is another common precipitant of stroke, and one that you commonly see when young people have a stroke. For those of you who are sports fans, there is a major star on the New England Patriots Super Bowl teams of the mid-2000s named Teddy Bruschi, and he actually was a guy who was younger than me, probably in his young 30s and at the peak of his career, and he actually had a stroke, not because he had any cardiovascular, or not because he had vascular risk factors or in atrial fibrillation, but because he had an embolic source from a PFO. So obviously when you're taking the history of this patient, in addition to what they presented with and their neurologic symptoms, which we'll go over in a few minutes, you're going to want to know about anything that contributes to vascular disease or any sort of hypercoagulable state. In young people, obviously the presence of a PFO would be investigated, but you'd also want to know if that person used illicit drugs or the person was on oral contraceptives or anything that would thicken the blood. Social history, obviously tobacco use is a risk factor for any vascular disease or blockage. You can have a variety of symptoms with a stroke depending on what part of the brain is affected. Here's just a list of them and in no particular order, and we'll talk about those as they've affected geographic area of the brain in a moment. We talk about things that could present like strokes, and if you think about this slide in reference to the clinical performance examination, you'd be thinking about things. If you thought someone had a stroke, you would list number 1 as ischemic stroke, but what would you list as number 2 and 3? What other things contribute symptoms similar to a stroke? Now, some of the things I'm listing on this page aren't otherwise on the list, so you probably wouldn't want to necessarily memorize these to write these down, but just so you know, these are the things that present very similar. Now, they did one study where they found out that they had neurologists evaluate a patient with acute neurologic symptoms and determine if they thought they had a stroke. And they got it right about 81% of the time whenever they got further advanced imaging. 19% of the time they missed it. And when they missed it, the most frequent mimics were seizure, systemic infection, brain tumors, low sodium or low sugar, or peripheral vertigo or conversion disorder, which basically means they have a psychosomatic cause. We'll go into seizures later, but a seizure could a seizure could present as a stroke in the fact that you could have some alteration or level of consciousness. You could have the seizure, have a postictal phase after, be found by your family with a postictal phase, and you could have actually a Todd's paralysis, TODD', where you actually have a unilateral or focal neurologic symptom that lasts with the um, with the postictal phase and resolves eventually, but it can present just like a stroke. In fact, if you want to know how that factor is clinically pertinent to my practice, is the TPA, or the clot busting medication that's administered within 4.5 hours of presentation of ischemic stroke that doesn't have other reasons not to give the medication. One of the contraindications is a seizure. And if they'd had a seizure beforehand, they feel like that means that there is a good likelihood that this was not actually a stroke, but a Todd's paralysis or a seizure mimicking a stroke. Now, certainly systemic infection could create confusion, and usually what it does is it creates confusion and global weakness. It doesn't really present with a focalizing finding, but in the acute setting where you don't have a good history and someone says, oh, grandma just started acting really, really sick all at once and looked very weak all at once, you obviously have the stroke on your mind, because a stroke can occur obviously as a quick pathology, and people can't give you the history that she actually been going downhill for a couple of days. You see a brain tumor on there. Obviously, a brain tumor, if you had a brain tumor, for example, you had a middle cerebral artery focality stroke, and it created a spectrum of symptoms. If you had a brain tumor in the same part of the parietal lobe as your MCA distribution of vascular supply, with a swelling or edema around it, then you could have the same symptoms from an MCA stroke as you would from a brain tumor. And that wouldn't be readily apparent always on the patient's history and physical and symptoms, unless you were able to get a CT scan or some sort of imaging. And then on down the list, we'll skip those and go on. And figuring out ischemic versus hemorrhagic stroke, which won't be an important part of your clinical performance exam. I hate to keep prefacing that, but I really want you to enjoy what you're learning in the lecture, and not think of everything as something to learn, or something to memorize, but something to just have in your mind. If you're trying to use clinical decision rules and likelihood ratios to determine whether a hemorrhagic stroke or an ischemic stroke, and we already determined that ischemic strokes are by far more common, patients who have coma, neck stiffness, accompanying seizures, diastolic blood pressure greater than 110, or vomiting are all more likely to have bleeding strokes or hemorrhagic strokes. Now, commonly these patients will present with pain and not just a neurologic illness, but not always. Here is an example of, on the left, the one with the goose egg here in the middle. That's obviously a hemorrhagic stroke or bleeding stroke, and that would present with the same neurologic symptoms perhaps as someone who had stroked in here. Now you can see these are ischemic strokes here and here that had a vascular supply knocked out. Now I can tell you that these are old strokes, and the reason I know that is because in the acute setting, commonly there are no findings on a CT scan for a stroke. Now, this is a pixelated image. I apologize for that. I thought it was better than this. This is a normal CT of the brain, and most patients who I see an ischemic stroke on who present to the emergency department actually have a normal brain scan. That's what makes diagnosis of stroke extremely difficult. In fact, diagnosis of stroke is the highest medical legal risk for emergency physicians, because it's very difficult. People will have a vague symptom or a focal symptom that doesn't reflect anything in illness. They can't articulate it very well. And if you get a CT scan, it won't look like this or this if it's an acute small ischemic stroke. You'll just show a normal CT scan. The edema would hopefully progress over the next several hours and present with after up to 24 hours with a CT scan finding. The only way to see a stroke in the acute setting on imaging is with an MRI, which is not feasible to do on every patient due to accessibility, time involved, and cost of an MRI. Now, TIA is basically just a mini stroke, and I think we've already covered everything we need to know about strokes, but TIAs and strokes will be two separate pathologies for a correct answer on your clinical performance examination. And the way you differentiate them is that mini stroke is basically the same general pathophysiologic process as a stroke. However, you don't get full infarction, you only get ischemia. And the symptoms, 80% of them resolve within 60 minutes. However, you have up until 24 hours. If the symptoms go away within 24 hours, classically is considered to be a TIA or a mini stroke. So if you see a patient and their symptoms have gone, then that would suggest that person had a TIA. If you saw a person whose symptoms were still there, then it would suggest a stroke. Some data suggests 10% of patients with a TIA get a stroke in the next 3 months or so, and about half of those people actually get about 5% in the next 2 to 3 days. That's why they recommend anybody who has a TIA to be admitted to the hospital to look for the cause of this TIA with regards to blockages or embolic source, and make sure they're on optimal therapy. So we're talking about classic symptoms that someone would have with a MCA stroke, which I think is your most famous stroke. It's basically your person with unilateral weakness and lost sensation over the left upper, or excuse me, not the left upper, over one side on the upper and lower extremities, as well as a facial droop. That person will commonly have difficulty with speech, difficulty with swallowing. They'll commonly have slurred speech and also difficulty expressing themselves. And it's not too uncommon that the person will also have some component of graphesthesia with their symptoms as well. I think basically what you would want to memorize is and learn, I say memorize, but learn would be that MCA stroke is your classic weak arm, weak leg, facial droop on one side with speech problems. So you can see this lady here has left facial droop, and the cartoon here next to it goes through some of the symptoms. You can see the person's right arm is dragging, their left leg is dragging, and their right face has a droop. One of the strangest things I've ever seen in my clinical practice was a lady who did cocaine when I was a resident. A lady did cocaine and came in and had a stroke immediately after. And we recommended her to have TPA, which is a clot busting medication, because she fitted into the window and didn't have any contraindications. So we set up to give that to her, and she actually refused it, got up, and walked just like the lady in this cartoon, dragging her right leg with a crooked face, dragging her right arm and her right leg out the ambulance bay, telling us that she didn't trust us and she wanted to leave. Interestingly enough, she went across town to another hospital, who then called us and tried to and requested transfer back within 45 minutes. But watching that woman drag her leg and arm out the ambulance door against medical advice is one of the strangest things I've still ever seen in my clinical practice. I want to bring one thing up here to you. I hope you can see my mouse as I move it here. This lady obviously has a facial droop on this side. If you had someone who presents with a facial droop but no extremity symptoms, a common cause of that is Bell's palsy with the seventh nerve palsy. What differentiates on physical examination, besides the presence of aphasia or speech difficulty, etc., with that would be in extremity symptoms on the arm and leg, is that patients who have a stroke spare the forehead and their symptoms, so they can actually don't have any forehead symptoms on the stroke. But if they have Bell's palsy, which is a facial nerve palsy, it actually does affect the forehead, so they can't actually wrinkle their forehead on that side. Again, this is not something for your clinical performance exam. But differentiating a stroke from a Bell's palsy is going to be something that will harass you the rest of your clinical career, depending on what you go into. And I just thought we'd go ahead and cover that a little bit. Next pathology to cover is a subarachnoid hemorrhage. Usually a subarachnoid hemorrhage is just what it says, which is extravasation of blood in the subarachnoid space between the P and arachnoid membranes, usually from a blood vessel. About 80% of the time it comes from a saccular aneurysm, about 10% of the time from arteriovenous malformation. Now, you can get a subarachnoid hemorrhage actually from trauma. That's probably the most common cause. People will bump their head. They'll cause a little shear force and get a little bit of bleeding in the subarachnoid space with that. But what we're going to cover here today is not traumatic subarachnoid hemorrhage from striking the head. What we're going to cover is spontaneous subarachnoid hemorrhage. And going back to that, put the brakes on and come back to it, is that's the one that has 80% of the cause are saccular aneurysms, and another 10% are arteriovenous malformations. Basically, weak spots in blood vessels in the brain rupture and lead to blood. Now, these present with a severe acute headache, commonly called the thunderclap headache. Usually when someone will come in and say that they feel like somebody took a ball bat and hit them across the back of the head with an immediate pop and painful sensation in the back. They don't necessarily feel a pop, but they immediately feel that acute pain. It doesn't always have to be like that. Some of these can present differently, but if you're talking about the classic presentation you expect on a clinical performance examination or a board exam, it would be an acute onset severe occipital headache. Classically, the buzzwords for that is thunderclap or the worst of their life. These people commonly have nausea, vomiting, sometimes have meningeal irritation from blood layered out. And when I say meningeal irritation, I mean the correct neck stiffness because of inflammation of meninges. They'll commonly have photophobia and visual changes. I mentioned down here at the bottom, seizures, syncope, and focal neurologic deficits. I don't commonly see those in my practice. Obviously, if it's a person who can give a history on a clinical performance exam, it's unlikely to have, it's unlikely to be an acute neurologic deficit with it. But I still say that you can have a neurologic deficit with a subarachnoid hemorrhage in certain circumstances, although that person is usually way out of it, and you basically get a semi-unresponsive patient who comes in, and you scan their head and you find out what it is. A clinical performance examination patient for subarachnoid hemorrhage would be a person who's able to come into your office and articulate the history. So this is not going to be a person who is laid up and unable to talk with neuro deficits. I've not specifically myself seen any acute seizures as a presentation of a subarachnoid hemorrhage, although it does mention in my research for this lecture that it's possible. And you can have a syncopal episode. Now you can have a syncopal episode associated with a lot of headaches. We'll talk about syncopal episodes later, but pain can be a stimulus for a pass-out spell due to a vagal phenomenon. But you can have a syncopal episode with the onset of a subarachnoid hemorrhage. So headaches that come on acutely with the presence of a syncope is very concerning to practitioners. Talked about this earlier, the breaking down of that. Now, congenital risk factors for aneurysms. In your family history, certainly if your family has these, there's a genetic component to it. And then basically polycystic kidney disease and other diseases of the connective tissue. I think if you have a patient who comes in with an acute onset severe headache, and they say, yeah, I've got Marfan's, I've got Ehlers-Danlos, polycystic kidney disease, that's what they're looking for in a board exam or clinical performance-based examination. If you're talking about other risk factors, you're talking about just vascular risk factors like we talked about in all patients with high blood pressure, smoking, atherosclerosis. We talked about the classic symptoms with an acute pain, with nausea, vomiting, sometimes meningeal irritation. Photophobia, we also mentioned in brief syncope. Here's a decision rule, which I like to show you guys decision rules because in the spirit of being a history and physical examination class, if you know validated decision rules that have been looked at through research in the literature, it can't help. And anytime you know these kind of things, it can limit your imaging. This is obviously not something that we're going to cover for purposes of clinical performance exam, but if you look through here, you can see that there are 7 characteristics that one decision rule said makes you strongly associated with subarachnoid hemorrhage and you should pursue further. Age greater than 40, witness loss of consciousness, neck pain, stiffness, manifestations with exertion, ambulance arrival, vomiting, or severe hypertension. Please don't go back and memorize that. I just wanted you to know that it existed. Physical examination, about half the patients will have a high blood pressure. You can have retinal hemorrhages 20 to 30% of the time. If there's mass effect, which that's not going to be a conscious patient usually, you can have papilledema. You can have global or focal deficit cysticism, about 25% altered level of consciousness. To be honest with you, most of the time when I see a patient who presents with a subarachnoid hemorrhage, they present comatose and nearly dead, or they present with an acute severe headache and either in a lot of pain or they're just drowsy. Occasionally be slightly confused, but drowsy with no focal deficits and no papilledema is my classic presentation whenever I see these patients. Sometimes I've seen them, they're wide awake, but if you're talking about someone who's worse than that, it's usually drowsy with global weakness rather than focal deficit. Differential diagnosis, obviously anything that causes severe headache. Now, meningitis obviously creates meningeal inflammation. We'll talk about that later, so that has that similarity. Cluster headaches can come on quickly, but usually in the front on one side of the sinuses. We'll talk about that later, and that can create it. Anything else that can cause a severe headache or neurologic symptom obviously is in play for differential diagnosis. if you had a patient you thought had a subarachnoid hemorrhage, it would not be unreasonable that your number 2 and number 3 diagnosis could be meningitis or cluster headache. And you could say, I thought it was subarachnoid hemorrhage because the patient had polycystic kidney disease and presented with an acute onset severe headache. And you could then say, alternatively, the person could have had a cluster headache because of an acute headache, but I did not think that the location fit perfectly like subarachnoid hemorrhage. Or you could say, I thought the patient had meningitis because they had a stiff neck. However, the patient did not have a fever, and the patient's symptoms presented quickly. Workup for this. When people come to the emergency department with signs and symptoms concerning for a subarachnoid hemorrhage, I send them over immediately for a CAT scan of the head without contrast. It's about 95% sensitive early on, up to 100% sensitive on new generation CT scanners. Now keep in mind it's a non-contrasted CT, so commonly it does not show the aneurysm or arterial venous malformation. What it shows is blood layering out. Now, the standard of care still in the United States that you're held to in the court of law, really, if it came down to a malpractice case, is that if you have someone who presents with a good history for a subarachnoid hemorrhage, if the CT scan of the head is negative, you should perform a lumbar puncture on the person. Lumbar puncture will allow you to look microscopically for heavy amounts of blood or look for something called xanthochromia. It starts with an X, xanthochromia, which is the appearance that blood has in the CSF. In the future, I think you'll see CT angiograms or a CT scan with an IV dye. Once you've got good studies showing that, I think that will help us show whether these people have subarachnoid hemorrhages pretty well. Now, again, this is not things for your clinical performance exam. I hate to keep harping on that, but I know the tremendous pressure that students feel to memorize everything. This is just so next year when you're seeing patients and they present with an acute headache that you're worried subarachnoid and the attending says the CAT scan was negative, are you done? You can say, no, I'm concerned enough that we could go on to lumbar puncture on this person. Here on the right is a subarachnoid hemorrhage. As you can see here, it layers out blood in almost a circle of Willis type distribution. It just layers it out right here. This is a pretty classic CT scan appearance. And right here is what you would see if you had aneurysm on a CT angiogram. You can see this here. The treatment is the ABCs, airway, breathing, circulation. You control their blood pressure. We can manage their intracranial pressure by their positioning, and if they're on the ventilator, perhaps with their respirations. But ultimately, you're going to call a neurosurgeon immediately, and they're going to be available to perform surgery or endovascular treatment, which is interventionally through radiologic procedure and angiogram. They actually go and repair the aneurysm that way. And that seems with a coil. That seems to be the preferred treatment most of the time. Migraine headache. So the next topic, I'm sure most of you guys have either know somebody that has migraines or have heard discussions about migraines plenty of times in your life. A migraine in layperson conversation really just gets equivocated with any sort of severe headache. But really, if you're talking about classic signs and symptoms of migraine, you're talking about a unilateral throbbing headache that is associated with photophobia, phonophobia, maybe nausea or vomiting, and is, when they talk about the definition, they say complex disorder characterized by recurrent episodes. And that certainly, I think that probably fits the perfect definition. Someone who recurrently gets unilateral throbbing headache associated with phonophobia, photophobia, and vomiting. Commonly, these patients will have an aura where they will have visual symptoms or neurologic symptoms that lead up to it. Now, how these neurologic symptoms lead up to it can also make it mimic strokes. We'll talk more about that in a minute. Here we see more on the symptoms. Now, migraine headaches usually come on slowly after a aura. If you're talking about a classic one, they don't always have to have an aura, but if you're talking about a classic one, and lasts from 4 to 72 hours. Features of the aura that precede the headache, they could go 5 or 20 minutes before. They can last less than an hour. They can last longer than that. You can have motor, sensory, or visual symptoms. The most common one that people classically describe is scintillating scotoma, which is a glittering zigzag in the vision. I'll show a picture of it, what people describe later. Physical exam findings of migraine, usually none. You can have anything on this list here. One I'll point out specifically is hemisensory and hemiparetic neurologic deficits, and that's when they call it complicated migraine. That's when the associated aura persists with the migraine actually present symptoms that have a focal neurologic deficit. You'll occasionally see people that have numbness and weakness on their arm, leg, face. They'll even have a facial droop. And at resolution of their headache or treatment of their headache, they will actually have resolution of those neurologic deficits. Most of the time people call that a complex migraine when it occurs like that. However, if you're talking about your basic migraine patient, most of them don't have any findings on physical examination. Here's migraine diagnostic criteria from the International Headache Society. It just goes over basically the same stuff we did earlier. Not something you need to memorize. There are a lot of theories for migraines, and some people feel like they're precipitated by stress, poor smoking, oral contraceptives, certain foods. They're more common in women, more common in Caucasians. Associated symptoms we talked about earlier, which is nausea, vomiting, photophobia, neurologic symptoms, and then occasionally the aura. Here are migraine visual symptoms. On your left is a scintillating scotoma, is some sort of complicated sketch artist came up with, I guess, based on somebody's presentation. And on the right, you see a central scotoma, which is a light in the middle. I think with your differential diagnosis of migraine, you're going to be looking at basically all other classifications of headache. You see that on the list. I think if you're seeing somebody for the first time that they've ever had a migraine, your biggest concern is going to be make sure that they don't have a ruptured aneurysm, a head bleed, a stroke, or something, brain tumor, something more severe, if you had to do it. But most of the time, migraine patients will have had these before. They can kind of tell you what's going on with them, if it's better or worse than usual. The workup and treatment, it's long and complicated, but there's a variety of behavioral modifications as well as pharmacologic therapies for migraines. We won't get into those too much today. Now, before we go on to cluster headache, let's stop and review what we talked about. A migraine headache is typically, if you're talking about your classic migraine headache, you're talking about a young white woman who presents with unilateral throbbing headache with photophobia, phonophobia, vomiting. They can occasionally have an aura with visual symptoms beforehand and flashing lights beforehand, and then have even neurologic symptoms with it. Now, if you had a person who presented on your clinical performance exam with, say, this classic headache, then you would go with migraine. If it was a headache, as I described earlier, if you had a patient who you thought had a stroke, but it had a headache with it, you might mention that stroke be your number one diagnosis, but you might say migraine. But the patient had absence of a headache, but a migrainous aura could present with unilateral neurologic symptoms. So you see how this goes. Or if you had a patient who presented with a migraine headache, you could say migraine number one, number two, subarachnoid hemorrhage, and you differentiate those in the assay. Cluster headache get their name because they come in clusters of severe headaches coming over a period of days or weeks. The International Headache Society also has a little list on this. I need to get an International Society of my own, definitely, so that I can be quoted multiple times in lectures. Basically, you get severe, and what they describe as strictly unilateral pain. And it says orbital, supraorbital, or temporal. So all around that area by the eye and the sinuses. 15 minutes to 3 hours, up to 8 times a day. And the episodes are typically associated with tearing, red eyes, runny nose, forehead sweating. It can also be associated with myocystosis or eyelid edema. And I'll put a picture with it in a minute so you can kind of visualize it. It's poorly understood pathology, like everything else. Looks like drinking and smoking is actually a pretty strong risk factor. It's more common in men over the age of 30. Here it just goes into the characteristics of it a little bit further. And associated symptoms. It looks like tearing and nasal drainage is your most common associated symptoms with the headache. Physical exam, honestly, most of the time in physical examination, if you see a patient who's actively having it, then you may see someone who is tearing, who has some eyelid ptosis, or has a flushed face with some sweating or runny nose. But most of the time you're going to see a person who's describing having had it earlier, and then probably most of the time they're going to have a normal physical examination finding, although here's a list of some things that can occur. Here's a guy with a cluster headache here on the right. You can see he's running his nose, he's tearing from his eye, and he actually has a little ptosis there with his lid lower on the right. The other patient in the black shirt here on your right as you look at the screen maybe has a little ptosis of that eye too, with a watering eye. So I would probably try to freeze that memory to your head with regards to that. Um, Cluster headache differential, obviously other sources of headache. Now, sinus headache can create sinus type pressure, but it's usually bilateral. It's usually a gradual onset. It's not severe like that. And guess what? If you're on a test taking strategy, if you see a person who you're between sinus headache or like a cluster headache, then you should know sinus headache is not on the list of 10 diagnoses. So hopefully you'll find out that that's not right. Because of the acute nature of it, subarachnoid hemorrhage could be in the differential diagnosis, but these clusters are repetitive. Cyclical migraines is just a type of migraines come in cycles. That would be in the differential as well, although you don't need to know the specifics about a cyclical migraine. Before we go on to tension headaches, let's go back and review what we talked about. A subarachnoid hemorrhage is an acute onset thunderclap headache associated potentially with meningeal signs of vomiting and altered level of consciousness, but not always. A migraine, a classic migraine patient, is a young woman with a unilateral throbbing headache with a preceding aura with vomiting, nausea, and photophobia. Potentially neurologic symptoms. A cluster headache is a quick-acting headache that comes on acutely, only on one side of the face, up and around the sinuses, associated with tearing, crying, sweating, and eyelid lag. And that's usually a middle-aged male who smokes and drinks. Now, going on the tension headache, this is probably the most benign of all the headaches we're talking about. Usually these are episodic headaches that occur with stressful events. It's really kind of a junk diagnosis headache, to be honest with you. If you got somebody you don't think has a severe cause of headaches, they don't fit migraine or cluster characteristics, I just hear doctors say, yeah, maybe it's a tension headache. Have you been under stress? So really it's kind of a junk diagnosis. I think that the most it's probably the most, it says here is the most common type of chronic recurring headache, typically more common in women and young adults. It's poorly understood. It could be muscular or psychogenic. What the IHS diagnostic criteria for this is a pressing or tightening headache in the front or the occiput on both sides, bilateral, moderate intensity, not worsened with physical activity. So if you're differentiating that from a cluster and migraine, clusters and migraines, or unilateral headaches, this is a bilateral headache in the front and the back. It's gradual onset, usually is non-exertional, which exertional headaches that are recurrent or more consistent with migraines, and exertional headaches that hit you out of nowhere, obviously more consistent with ruptured aneurysm or subarachnoid hemorrhage. Here's tension type headache, which is slightly differentiated from tension headache. Honestly, I wouldn't spend a lot of time on that slide. So if you're talking about your classic person, it says vital signs should be normal, but very seldom do I see a patient with normal vital signs in the emergency department because everybody's in pain, everybody feels bad, they're stressed, and so their blood pressure's up. A person should have a normal neurologic exam. They may have tenderness in your scalp or your neck, and typically you got a normal neurologic examination. Differential diagnosis and treatment is basically all other headaches, but basically, if you think about it from this perspective, like I talked to you about earlier, this is a moderate severity, recurrent, common headache with stress, frontal, occipital, and bilateral, not throbbing. It's a tightening type headache. So there should be a lot of factors that can differentiate that for you. The treatment is everything from relaxation to dietary techniques to trigger point injections and nerve blocks. Here's headaches as a glance. The sinus headache obviously is not on your list, but you can see here the cluster headache where it's located, the tension headache and squeezing, the migraine, as you can see, that's kind of the general area. I thought sometimes people are visually capable of picking things up and forming an imprint and image so they can try to differentiate things more than talking. So we'll thought I'd put that in there. Now, before we go too far past the headaches, we've talked about subarachnoid, migraine, cluster, and tension. I think it's safe to say that if you have a patient who presents with a headache syndrome with no focal neurologic deficit, i.e. they don't have a numbness or weakness on one side of the body that would be consistent with like a stroke, that person on your clinical performance exam, you're going to take the full history and physical. and then you're going to do a full neurologic examination on the person. And then probably, if you have time, you're going to do a fundoscopic exam. To be perfectly honest, I don't think that you're counted off specifically for not performing a fundoscopic exam. And certainly, the standardized patients are not going to be able to tell if you can or if you do or don't know what you're doing on the fundoscopic exam. But in the real world, you should practice the fact that if you see anybody with a headache you're trying to figure out, you should be looking at a fundoscopic exam in order to try to determine if they have papilledema. It's very important because papilledema could be is a reflection of a space-occupying lesion that's creating increased intracranial pressure, and that's going to take you away from your basic migraine tension cluster headaches and more toward the brain tumors and other pathologies. Okay, let's go on to the next here. Sorry, I had to take a little delay there. I was doing some IT work here. Brain tumors, they can be primary tumors or metastatic disease. You can get a primary brain tumor in your brain, or you can get tumors from other causes, renal cell, lung cancer, etc. Headache is customarily your first symptom of a brain tumor, but not always. Sometimes those patients will present, as we talked about earlier, as a mimic for stroke. They'll present with a focal neurologic deficit based on their space-occupying lesion and their edema, and the differential diagnosis will be more based on the stroke. Most headaches in patients with brain tumor are pretty nonspecific, and they may even just be like a simple tension headache. If you get an old person that gets new headaches, then obviously that's of concern. If they're in the posterior fossa, they seem to hurt more and have more association with headache. I think your classic case that people will always expect you on a clinical performance exam or board exam would be a headache that's worse when they're lying down and when they wake up in the morning because the supine position may elevate their intracranial pressure. To be honest, in reading and preparing this lecture, it doesn't seem that the supine nature with the worsening headache in the morning is of any real statistical consequence, and probably not a factor you should hang your hat on for the future. But for purposes of tests, if a headache's worse when they're lying down, that would be a concern. Your differential diagnosis is basically anything that creates headache, confusion, or a focal neurologic deficit. These people can be confused. I've seen people only with confusion. I've seen them with focal neurologic deficits. I've seen them with severe headaches. I've seen them with combinations of those. And you don't usually know what's going on until you get some brain imaging. Even a neurologic exam occasionally won't yield anything, or even papilledema. So a physical examination, you could have nothing, or you could have a focalizing physical exam finding. You could have papilledema. Brain tumors, your really differential diagnosis, anything depending on the presentation. If they have a headache, the differential diagnosis is other headache syndromes. If you have a neurologic presentation with focal neurologic deficit, then strokes fit more into your differential diagnosis. I will say that because brain tumors can present in a variety of ways, I don't want you stressing out about it. If it's a case on the clinical performance exam, it'll be very straightforward. It'll be obvious that you have dealing with a brain tumor, and it'll be presented in a way that make it clear.